Hello. Thank you, Prof. Bikun, for the kind introductions. Good afternoon, everyone. I'm Dr. Teh. Thank you, the organizing committee, for inviting me to share on this topic, nutrition for elderly, the impact on mental health on lifestyle adaptations. Actually, this is quite a broad spectrum topic, not easy to talk about. And I have been thinking about it, how to present and share my knowledge and experience with you all in this short 25 minutes. Yeah, so let's move on. Let us start with introductions. According to the statistics from World Health Organizations, there are about more than 20% of older adults aged 60 and above suffer from a mental and neurological disorders. And the most common mental and neurological disorder in this age group are dementia and depressions. Actually, mental disorder is a broad spectrum of diseases. Yeah, it can start from mood disorders, for example, depressions, bipolar disorder, until anxiety, depressive disorder, panic attack, obsessive compulsive disorder, schizophrenia. There's lots more of the mental health illness. And neurological disorder also a lot. But for elderly, the most common one is actually dementia and depressions. Today, my talk will mainly focus on dementia. Yeah, because this is very prevalent in older persons and we hardly talk about it. And many people don't know how to manage person with dementias properly. It ended up a lot of dissatisfactions and feeling failure, feeling very sad when they are handling person with dementia. So today I will share with you my knowledge and experience how to handle person with dementia. So as we all know, the world population is aging rapidly and the number of older people in this world is going to double from 12% to 22%. So as the number of older people is getting more, we are anticipating more and more people with dementia is coming to us. Are we ready to manage them or to help them? Yeah. So let me give you some introduction about dementia. A lot of people ask me, Dr. Teh, what's the difference between dementia and Alzheimer's disease? So let me share with you what is the difference or what is the relationship between dementia and Alzheimer's disease. Actually, dementia is an umbrella term. So it's a common term for us to use to describe a group of symptoms because of loss of memory and other cognitive functions, which is severe enough to interfere with daily activity. All of us, as we age, of course, our memory and cognitive function not so sharp as compared to when we were young. But this deterioration, it shouldn't affect our daily life. Once this deterioration in cognitive functions affect our daily life, means it is a dementia. It is not a normal aging process. It is a disease. And what diseases causing dementia? There are many neurodegenerative diseases can lead to dementia, which are Alzheimer's disease, Lewy body dementia, vascular dementia, frontotemporal lobe dementia, Parkinson's disease dementia, so on and so forth. There are a lot of neurodegenerative diseases can lead to dementias. And some patients, they have mixed etiology. They can have two pathology together in their brain, that leading to the presentation of signs and symptoms of dementia. So now you know what's the difference between dementia and Alzheimer's disease. So Alzheimer's disease is one of the diseases that can lead to dementias, and this is the most common cause for dementia in older adults. And in the latest DSM-5 diagnostic criteria, they changed the terminology they use for dementia. From dementia, now we use the term major neurocognitive disorder. So when you see the research paper or the textbook, they write major neurocognitive disorder, it means dementia. It is the same. We can use it interchangeably. How common is dementia? Of course, the prevalence of dementia will increase as the age increase. If you look at this graph, if 60 to 69, the prevalence is not so high. For 70 to 79 is higher, 80 to 89 will become higher, and then 90 is become very high. So the roughly is about 1 in 10 for the age of 80s, 1 in 5 in the age of 70, 1 in 3 in the age of about 80s, 1 in 2 in age about 90s. This is a rough estimations. And how common is dementia according to Alzheimer's disease international data? Every 3 seconds, there are someone in this world diagnosed with dementia. So it is so common. So 1, 2, 3. 3 seconds, there's someone in this world diagnosed with dementia already. And the number of people with dementia will increase dramatically. This is the estimations before the COVID era. They estimate in year 2015, the number of persons with dementia in this world will be 130 millions. Yeah. But after COVID, we are anticipating actually the number will become more. Because of the social isolation and all this, it will lead to more people will develop dementias. And there are evidence to show that people post-COVID, the risk of develop dementia is higher than those people without COVID. So next we talk about malnutrition in older populations. According to the systematic review and meta-analysis, the prevalence of malnutrition actually varies because of the different criteria they use. And there are regional variations also. So the regional variation means for the developed country, the rate of malnutrition in older population is lower compared to developing country. And the study in community dwelling older adults using the mini nutrition assessment MMA, it shows that about 3.1% of the community dwelling older adults had malnutrition, and 26.5%, about 1/4 of them, are actually at risk of malnutrition. And of course, if you do the malnutrition study in institution, nursing home, care homes, the rate of malnutrition or at risk of malnutrition will be higher, even higher. And the risk factors for older people to develop malnutrition, actually there are a lot. I pick up a few which has high odd ratios one. Of course, number one is age. The older you are, the higher the risk you get malnutrition. Frailty, Parkinson's disease, constipation, dementia, eating dependence. Eating dependence means they are unable to feed themselves. They need people to feed them. And dysphagia, difficult in swallowing. Yeah, these are the risk factors for malnutrition in older populations. And for persons with dementias, the prevalence of malnutrition is range about 7.8 to 6.8% to 70% like that. And at risk, of course, is going to be higher. So as a pool prevalence from the meta-analysis, it shows about half of the person with dementia, actually they are at risk of malnutrition. So next, I'm going to share about why person with dementia are at higher risk of malnutrition. For clinicians, what we observe is the reason or the factors leading to poor appetite or poor nutrition in person with dementia, actually it differs according to the stage of diseases. So different neurodegenerative disease, the rate of the disease decline is different. Some were faster, some were slower. And for Alzheimer's disease, the most common type of the neurodegenerative disease, usually the disease will deteriorate about in 10 years' time, from the early stage until the patients pass away. So for all the dementia, at this moment, there is no curative treatment. The treatment available at the moment is just to delay the disease progress. Eventually, the patient will progress also. So for early dementia, it means the person of the dementia still independent for the activity of daily living. They still can feed themselves, go to toilet, bathing, toileting themselves, walk independently, no problem. For moderate disease, it means they need some help for their activity of daily living. Means maybe they can feed themselves, but they need some help for bathing and changing clothes. For severe disease, means they are total dependent. They need people to help them in feeding, changing, they are on diapers, they cannot ambulate anymore. So these are severe stage. Okay. So the factors or the reasons for malnutrition for early stage and moderate stage of dementias, it can be divided into cognitive issues, behavioral and psychological symptoms of dementia, BPSD, or the change in sensation. Let us look at the cognitive issue first. Of course, dementia, what is the most marked symptoms, most obvious symptom is forgetfulness. Especially, they have impact in recent memory. They forget whether they have taken their meals or not. Yeah, there are two groups of patients. One group of patients, they forget they've taken their meals, they always ask for their meals. Yeah, this is also a trouble, especially for those diabetes patients. Yeah, it's going to be a trouble. But another group of patients, they not just take their meal, but they said they're full already. They have taken their meals. They refuse to eat. Yeah. So these two groups also going to have problems. So these are the reasons because of the cognitive issues. Number two is confusion about time. Yeah, they don't know when is the meal time. They're confused about that because of disorientation due to cognitive decline. Number three is due to the cognitive decline, they lost their ability to prepare food or to go and buy food for themselves. For example, one of my patients, she is a good cook. She only eat the food that cooked by herself. She refused to eat the food outside or prepared by others. She said the taste is not what she likes. But as the disease declined, she lost her ability to cook anymore, to prepare the meal for herself. That's why it affects her appetite. Yeah, so these are the factors we need to consider. Number two is BPSD. For example, 30% of the person with dementia, actually they have depression, coexisting depressions. As we all know, depressed patients, they have loss of appetite. Number two, some of them will become suspicious and paranoid. They are always frightened, they worry about people who put poison in the food. That's why they refuse to eat, especially when they're in a strange environment, when they're admitted to hospital or they're in a care home, not a familiar environment. They refuse to eat because of this suspicious and paranoid behavior. Number two is they become easily irritable, agitation and anger, aggressions. So when you're angry, then you have no appetite to eat. Number three is change in sensations. Person with dementia, they might have change in taste and smell also. So sometimes you need to know whether the change in taste, it will affect the food that they like. Yeah, so it might change in the choice of food as the dementia disease progress. And some of them, their lack of the sensations of hunger and thirst. So don't wait for them to ask for food. We should always offer food when the time comes. So offer regular meals. Okay. For the severe and advanced stage of dementia, the most common cause for malnutrition is actually dysphagia. All the person with dementia as the disease progress up to the severe and advanced stage, they have difficulty in swallowing. So a lot of time we say they forget how to swallow. They hold their food for very long because they are unable to recognize or sense the food in their mouth. So we need to stimulate them and remind them. So sometimes to feed a person with severe dementia, we need about 1.5 hours to feed just one porridge, one bowl of the porridge. Because after we feed, we need to remind them, please swallow, open your mouth. If they not just swallow, then we need to trigger them, double swallow. There are techniques to handle this type of patient you need to learn from your speech and language therapists. Yeah. And of course, there are lack of attention during the severe stage. When we finish a meal, we need to have focus and attentions. For person with dementia at severe stage, the attention is not there. Maybe during your feeding time, they will doze off, they will sleep. So you need to make sure they're awake. If they sleep during your feeding, they might aspirate. It causes aspiration pneumonia. This is also a problem. So a lot of healthcare professionals and family members, they are struggling with feeding during this stage of diseases. So tube feedings is always a yes and no answer. There's not an easy answer whether to put in tube feeding for advanced dementia patients or not. There are risks and benefits, and the evidence is actually contradicting each other. Some studies shows there are benefits, some studies show no, it won't prolong the lifespans. It won't reduce the risk of aspiration pneumonia. But some studies say it actually reduce the risk of aspiration pneumonia and increase the lifespan. So the evidence are contradicting. For clinician doctors, usually we discuss with the patients and family. We will encourage the person with dementia to make advanced directive or advanced care planning at the early stage of disease when they still have mental capacity to make decisions for themselves. As the disease progresses, when they are unable to swallow, whether they prefer a tube feeding or they don't want a tube feeding. If the person with dementia decide for themselves, then it's easier for everyone. Yeah. So it depends on the culture and the family members and the patients what they want. So the key point here is to discuss with the persons with dementia and their family members. No easy answer, yes or no, about tube feeding. So apart from those symptoms related to dementia itself, there are other causes that can lead to poor nutrition or poor appetite in person with dementias. For example, medical conditions, infections, malignancies, reflux diseases, sometimes toothache, oral ulcer, all these common things that we neglect about them because person with dementia, they're unable to tell you what's wrong with them. So you need to check thoroughly what's wrong with them. So if let's say an oral ulcer or toothache, then just refer them to dentist, get it settled, then they'll have a better appetite. Okay. So sometimes we could, due to the poor dentition, yeah, the toothless, they're difficult to chew and bite, or the denture actually is not fitting properly. It's causing frictions and oral ulcers. Yeah, so this one you need the help of dentists to help them to chew and bite better. Okay. Number 2 is for polypharmacies. Some of the medicines actually can suppress appetite or causing gastritis and poor appetite, nausea, vomiting. So for example, painkiller, NSAIDs, all these Ponstan, Voterans, and opioids, your tramadol, morphine, it can cause nausea, vomiting. NSAIDs, it can cause gastritis, and then they have poor appetite. Some antibiotics will lead to poor appetite also. Some will lead to GI upset, diarrhea. Yeah. Antidepressants. Just now I mentioned depression is a risk for malnutrition, but the treatment for depression itself also can lead to suppressed appetite, especially the SSRI group. For example, your fluvoxamines, fluoxetines, all these SSRI group, it can suppress appetite. And then choline esterase inhibitors. This is a treatment for dementia itself. So there are 2 choline esterase inhibitors, the donepezil and rivastigmine. And then certain patients, some patients, about 3 to 5% of the percentage of the person with dementia, they have this suppressed appetite as a side effect of this treatment. So some of the person with dementia, they have lost appetite because the doctor start this treatment for dementia. For example, one of our patients, she was on these dementia medicines, donepezil, for 3 years. For past 3 years, she has been admitted to hospital, in, out, every year, 2 to 3 times for gastritis. Then the surgeon scope up and down, and then significant weight loss. They cannot find the reason. All the tumor marker normal, scan normal, no cancer. So at the end, when they referred to me, and then I stopped the medicines, donepezil, and now she's okay. She gained back 5 kg in 6 months' time. Yeah. So medicines itself. And overdose of digoxins. Digoxin, a normal dose for young people, can be overdose for elderly. So the prescriber must be very careful. Chronic constipation, yes, it can lead to poor appetite. Reduced physical activity, it can lead to reduced appetite. Because as the person with dementia becomes inactive, less mobile, the energy they spend is become less. Then automatically, the body will send the message to the brain, you no need so much energy, you no need to eat so much. Yeah. So sometimes increased activity will stimulate the appetite. So encourage them to do physical activity. Of course, social factors and financial factors also need to consider. It can be a cause of malnutrition. So now I would like to share about strategies, nutrition strategy of person with dementia. I'm not a dietitian. I'm unable to tell you how many calories to take, how many protein to take. Usually I refer to my dietitians. I will share with you the strategies, how to encourage the person with dementia to eat or to eat better. Okay, I would like to share with you this concept, person-centered care, PCC. This introduced by Professor Tom Kitwood in 1997. This is actually the fundamental emotional needs for person with dementia. So it is also a marker or aspect of well-being for person with dementia. Actually, not person with dementia. I think all people, every patient with psychological disorder, they also need this type of approach, person-centered care. Number 1, they need to be comfort. So from the nutritional intake, you need to know what's the comfort food for the person with dementia, what they like, what they don't like. Some people like spicy food, some they cannot take spicy food. Some like savory, some they don't like. So you must know what is their comfort food. Some is lactose intolerant. You cannot give milk, you'll cause diarrhea and upset for them. Then they will hate you, right? So you need to know what is the comfort food for them. Number 2 is identity. Everyone have identity. So from the choice of food, usually you need to know what's their cultural background, what's their religion background. So there are something that they cannot take. For example, Muslim, you must prepare them halal food, vegetarians, yeah. So they have their identity. And some cultural background, there are certain food they prefer. Yeah, you have to design your food menu according to their identity. For occupation and inclusion, occupation doesn't mean what job they did before. Occupation means get them occupied. Get them involved in the food preparations. Inclusion also same. We don't want to isolate them. You sit down there, I prepare the food for you. No, usually if possible, get them to help in the food preparations. For example, you bring them out to the market to choose what they want. Yeah, so then we prepare the meals together. Then they'll have the enjoyment, then they'll enjoy the food, they prepare themselves better. Last one is attachment. All of us got something that we attach and we like. So for person with dementia, you must know what's the attachment. For example, they have a special cup that they like. Yeah, you must use that cup or their own bowl or a special place they like to sit. Yeah, so attachment. So for inclusion occupation, for example, in care home, nursing home, also usually we encourage to sit down and eat together. Don't everyone eat on their bed. Isolate them. No. Usually, if let's say you put them all sitting together, sometimes as they eat, they chit-chat, they can encourage and stimulate each other to eat more. Yeah. So these are the concepts for you to apply. And of course, we do all this for the with the sense of full of love. Then they can feel it, and then they will eat better. Okay. So those are the theory. Come to the practicals. These are the principles of the person-centered care. You must treat them as your VIPs. V stand for value, so you must value them, respect they are as a person, not as a patient. Usually respect them as a person. They have their own preference, and then they have their own value. Number two is individualize. Every person of dementia is different, like what I said just now, they have preference of food, and they have strength and weakness. Those are dysphagia one, you need to refer to speech therapy to see what type of food they're suitable, mince or moist, or you need to mix mixer in the drinks to reduce the risk of aspirations. Individualize the meal choice. Perspective, knowing what is important for them. For example, if they refuse to eat, don't force them. You need to find out why. Is it they are unwell, they are sick during that day, they have some toothache? Be sensitive to the unmet needs. Number four is supportive. Create a supportive environment so that they can enjoy the food with their friends or family members better. Don't exclude them from the society or the family. Okay. So I always receive these questions, vitamin or supplements can prevent cognitive decline or not? So from doctor point of view, of course, we always look at the evidence. So a lot of, I would say, contradicting evidence available. Some said some supplements will prevent cognitive decline. Some said no effect. But the pooled data from the Cochrane systematic review, it shows that actually there is no evidence that the nutrition supplements can delay or prevent the cognitive decline in healthy people. Healthy people. The keyword here is healthy people. They don't have malnutrition issues. Then if extra supplements, actually it didn't really prevent the cognitive decline. Okay. But as we know, B12, folate, and thyroid functions, thyroid deficiencies, it can lead to cognitive decline. So for a doctor, usually the person with dementia, they come to me with the problem in cognitive decline. We run some blood tests to rule out all these potential treatable conditions, B12 folate deficiency, especially in vegetarian patients. They tend to have B12 deficiency. Those patients, they don't like vegetables one, they have folate deficiencies. Yeah. So all these are potential treatable, then we want to treat it. Okay. So in conclusions, actually a healthy balanced diet will do. With adequate essentials, vitamin and minerals, healthy balanced diets is already adequate for brain health. There's no evidence to support that using extra supplements can prevent cognitive decline. But the what work for cognitive preventions is the multimodal interventions. You need to include physical activity, brain stimulations activities, control your cardiovascular risk factors, stop smoking, moderate alcohol intake. All these multimodal interventions will reduce your risk of cognitive decline, not only the food supplements. Okay. I think I finished early. Thank you everyone for your attention.